Thank you so much for inviting me to this meeting. My name is Tomas Aleman. I'm based both at CHOP and at Penn in the Carrot Center, which is a specialized unit which I direct the clinical part of it. We're basically uh, involved in trying to understand retinal degenerations and try to treat them mainly with gene therapy. My specialty is retinal degenerations, and basically what we do is deep phenotyping of patients with these conditions. I have no disclosures. So why is that is important to examine the eye in mitochondrial disease? So in the talk today, I'm going to go through the way we examine the eye and why we do it, and the visual symptoms that the patients may have, as well as how do we do the evaluation, and give you some insight on what the tests that we do, what do they explore, and what is the significance of each one of the findings, um, as well as a general classification of the ophthalmic findings in these diseases, which I'm going to try to illustrate through relatively common conditions. As you know, these are not necessarily frequent. Have the we are in the position to see patients with these conditions being a tertiary referral center. So the eye can serve as a surrogate organ to look into mitochondrial diseases. We have access to the motility of the eye, which is carried out by a number of muscles. It's one of the most innervated organs in the body, both the muscles that are in charge of moving the eye around, as well as the muscles that are in charge of moving the pupil, are part of a very dense neuromuscular complex of reflexes. And if you look beyond the pupil and look in the back of the eye, this is what you see. This is a picture of the retina of a normal subject. And we can not only see the retina from above and see the center of our vision, which is the fovea, the little spot in the center. We can also examine the nerve, which obviously is what connects the eye basically to the central nervous system. If we look at the retina, specifically in cross-section, the retina can be simplified as a tissue with three main layers of neurons and supported by a basal layer of cells that are in charge of the transport of nutrients and carrying out debris and toxic byproducts from vision. So the three layers that we talked about are basically the photoreceptor layers, rods and cones. Rods, cells that see mainly in dim lighting conditions, and cones are the cells that see in daytime and provide color vision. Bipolar cells, which are the second neuron in the pathway towards the brain, and then the ganglion cells at the surface of the retina, which connect to the brain through their axons. In clinic, we actually can examine these structures in vivo, non-invasively, with a technology called optical coherence tomography. It's basically a technology that uses laser interferometry to scan the retina up to 2 microns, to create sections of the retina up to 2 microns in resolution, as is demonstrated here. The picture to the left is a cross-section from a histological sample. To the right is a retina in cross-section through this modality OCT. Each one of the nuclear layers are actually dark in this type of representation, and you can see the three layers of the cake, as I usually. And you can also see the synaptic layers, which in this case are brightly illustrated. They are bright layers that reflect light and refract light intensely, as well as the axonal layer, the nerve fiber layer, which is the extension of the ganglion cell bodies, the axons of the ganglion cells as they travel towards the brain. So each one of those layers can be sampled easily in vivo. More importantly, we can actually see the cilia of the photoreceptors. The retinal photoreceptors are actually ciliated cells, like are the cells in the inner ear. And in this imaging modality in the clinic, we can see the structures of the outer retina. They're very important because if we lose any of this structure, even if you have the entire retina intact, you will lose vision. They are the vision capturing, the light capturing organelles within the cells. And they are very rich in mitochondria. In fact, this layer that we see here in the outer retina, that we call the ellipsoid layer, is actually, it is thought to represent the reflection of the mitochondria rich inner segment ellipsoid region. The cilia follows, and then the retinal pigmentary epithelium, which, as I mentioned before, is in charge of maintenance, and it's super important for the functioning of the retina. You can see here in this cartoon that the accumulation of mitochondria occurs near the inner segments of the cilia of the photoreceptor. Are these structures here? This is a rod and this is a cone. The name implies the shape of the outer segment, and the mitochondria accumulates in the inner segment, which generate that bands that we were talking about. And then also the Mueller cells, which are the glia that holds the retina together, are very rich in mitochondria. And lastly, the pigment epithelial cells, which are at the base of the photoreceptor cilium, are extremely also rich in mitochondria. So we have a situation where we can, by just examining the patient, explore first the muscle that moves the eye and that moves the pupil, and that you can do it just by looking at the patient and ask them to move their vision in the cardinal positions of gaze. The symptoms that are related to problems just of the motility of the eye are typically ptosis, so a droopy eyelid, and double vision. In the case of the inner retina or the outer retina, which are bracketed here in orange, the symptoms are typically that of vision loss. I should mention that in many of these cases, the patients are totally asymptomatic, and also that these things are not in isolation, that often actually you have a interplay between problems of motility in a retina and the outer retina and the pigment epithelium. The symptoms of mitochondrial disease, in addition to the diplopia, the problems with the droopy eyelids, the interference of the eyelid and droopy eyelid with vision, are symptoms that primarily reflect problems with fine discrimination, such as inability to read a small print or to read signs on the street or to do fine handiwork, as well as problems in dim lighting, like driving at night, which is a very complex visual task. The mitochondrial disease may be then described with classical representative conditions, which I'm going to present to you today. One is the one that affects the external motility of the eye more kind of in isolation, is something called chronic progressive external ophthalmoplegia. A disease that example of diseases that primarily affect the optic nerve and the inner retina are Leber's hereditary optic neuropathy and, in general, optic nerve atrophies that are genetic in origin. And in the outer retina and retinal pigmentary epithelium, you have Kearns-Sayre, NARP, MELAS, and MEAD. So chronic external ophthalmoplegia has an onset in early life, in childhood or early adulthood. It's characterized by a slow bilateral onset of ptosis, which may be overlooked initially. Only when we looked at pictures do we realize that patients were having this problem from early life. The patients actually complain of very minimal symptoms in general, but of course over time they become significant and they impair vision by just occluding the axis of our vision. Sometimes they are drifting of the eye, typically outwards, which we call divergent extravisms or exotropia. and typically they don't produce a lot of symptoms early on. The patients adapt by turning their heads and doing tricks to compensate even without knowing. And then the mutations that are associated are usually heteroplasmic deletions in mitochondrial DNA, which are much more variable but in a similar location as we see in Kearns-Sayre. This is an example of a Kearns-Sayre syndrome patient. This is actually from the initial report of the initial 2 cases where this patient, for example, had noted problems with fatigue for years before he consulted his primary physician, had extreme bradycardia, and that was the initial kind of trigger that something was happening with both his eyes and his heart. So the association of a problems, so a CPEO situation, heart conduction abnormalities, and retinal degeneration then came to be known as a Kearns-Sayre syndrome. Of course, they have other symptoms depending on the severity of the disease. This is an example of one of our patients, a 19-year-old female who presented with mild hearing loss. She was referred by you guys for evaluation. She had basically no visual symptoms. Her acuity was at 20/25, which is pretty good. It's not entirely normal, but we wouldn't call it abnormal. We'll call it subnormal acuity. On the left is a picture of her fundus, and the inset to the left, top left, reminds you of how the fundus should look. You see that it's not as orangey. It's kind of not as, you don't see it this well here, but the fundus is being described as salt and pepper fundus with some pigment changes and bright whitish spots. The OCT cross-section, which is right in the middle panel, you can see ellipsoid abnormalities. I have a small inset to the top right to remind you that you should have this comb-like multi-layer structure in the outer retina, which is obviously not normal in the patient. And again, you can do electrophysiological recordings in these patients with something called the ERG and detect an abnormality in the electroretinogram is critical in some cases. When we think it's warranted, we want to know if the abnormalities are local or if they affect the entire retina. And you can objectively measure that. This lady up here to the left is wearing the contact lens, which is attached with a wire to a computer and which records signals directly from the outer retina, which is this down-going wave that you see here at the beginning of the waveform, and then for the signals also from the inner retina, which is the second upgoing waveform, which we call the. This is another example of a 13-year-old who was actually referred initially to the oculoplastic surgeon's shop with ptosis, thought to have been congenital ptosis. His vision would not correct past 20/80, and then a problem in the retina was suspected. I don't have a picture here of the retina, but the picture was not that impressive. But when we did, again, the OCTs, you can see that the lamination of the outer retina, instead of having those 3-4 bands, you have none. So again, basically an undetectable ellipsoid band causing a severe loss in acuity. And then this kid was diagnosed with mutations and was diagnosed with Kearns-Sayre. This is another example of abnormalities that are both in the outer retina and the retinal pigmentary epithelium. In this case, a 40-year-old female who had presented initially with seizures at age 38, I believe. She had also a history of progressive hearing loss, starting in early adulthood in her 20s, and she was admitted several times at HOP for concerns of stroke-like episodes. And you already know the diagnosis because we are in the mitochondrial seminar, but right here, the fundus is not that impressive, but you can see that there are spots where things are a little bit darker. They look like blackish or grayish compared to the surrounding. And you can actually image the melanin, which are, when we see pigmentation in the retina, typically represents reactive hyperplasia of the retinal pigmentary epithelium. The retinal pigmentary epithelium is rich in melanin, And we can, in a normal subject, for example, to the left, image that using infrared lights. When you irradiate the retinal pigmentary epithelium, there is a fluorescent signal that is produced, and it should look like this: gray, homogeneous, brighter in the center, a little bit darker as you move away from the center, but nevertheless a grayish homogeneous background. In comparison, you see this pattern, which is very similar to a group of diseases, genetic diseases of the retina, called pattern dystrophies, where you have this hypo autofluorescence. So there is loss of the melanin all across the RPE in the central retina, and areas where you have pigment hypertrophy. And notice that the arrows are pointing in the same places where we pointed before, that there were kind of grayish areas. So the very bright kind of clumps represent RPE, probably loss and migration. In cross-section, when you go through those lesions, again, you realize now that the abnormalities are indeed in the outer retina, both in the area where we have the cilia of the photoreceptor and the so-called inner segment or ellipsoid region, as well as in the retinal pigmentary epithelium, as is circled here in red. Again, all of these are mitochondria-rich retinal structures. Lastly, this is an example of a 16-year-old young lady that presented very early to CHOP with hearing loss. She was given a cochlear implant. For the longest time, she was thought to be a form of Usher syndrome because she had two variants of unknown significance in an Usher type gene. But things did not make a lot of sense, and she was referred to us. When we examined her, we noted pale optic nerve. As you can see here, the nerves are no longer pink, they're almost white. And you know the diagnosis. The cross-section in this patient compared to a normal show a dramatic loss of ganglion cells. So the most superficial of the three layers of the cake is very thin, and she was diagnosed with Wolfram-like syndrome. She didn't have all of the components of the syndrome, but was diagnosed clinically as such. Usher syndrome was ruled out because in Usher syndrome you would expect to have a major problem in the photoreceptors themselves, not in the inner retina. And this was exactly the opposite in this patient, and she was found to be positive for the mutation. So we went ahead and did a mapping of her ganglion cells, which are the primary target in this situation, and compared to a normal where the ganglion cells should be highest in density around the foveal center. The foveal center is the blue spot. In the case of the patient, you see that that yellow ring is, or donut, as I sometimes call it, is totally lost. The comparison with the normal map is done below, where you see that everything is in red, implying that she's really abnormal beyond 99% of confidence compared to a normal subject and a normal database. And we can do tracking of the axons of those cells, of the ganglion cells, by doing a mapping of the retinal nephrolator layer, which you can see here on the left. We do it through a circular scan here to the left. This circular scan would basically be sampling 100% of the axons that are leaving the eye, and you can generate a map of the thickness of the ganglion cells, of the RNFL. You can see that it's highest as in the inferior and superior pole of the nerve. In the patient, all you see is blue. There are no bundles, and this is despite the fact that the patient only had 20 or 40 acuity loss. So in conclusion, I hope I have convinced you that our exam, despite the fact that sometimes it's entirely normal in some cases, is important. We provide feedback for the diagnosis of these diseases, and perhaps for your treatments and the treatments that you're attempting to introduce to these patients, perhaps in a research setting. We are able to correct some of the abnormalities and offer advice on what to do and not to do when we detect abnormalities. For example, we can correct surgically some of the droopy eyelids that are interfering with vision, as well as correcting double vision with prisms and surgery. But also we try to protect these patients from light by giving specific supplements and protect their retina with some supplements, as you may have encountered with us when we send the recommendations back. And finally, in many cases where you and us, we are both troubled that we cannot come up with a diagnosis, we do find minimal abnormalities in many patients that we wonder if they can be explored further, and that minimal abnormalities may become outcome measures for your trials or markers of phenotypic expression in the eye for this group of devastating conditions. Thank you so much, and I will answer any questions.